Hello, and welcome to the Domestic Violence Response Initiative training program from the Maine chapter of Physicians for Social Responsibility. I'm Dr. Daniel Oppenheim. I'm a practicing endocrinologist at the Maine Medical Center, and I've been involved with PSR for more than 25 years.
And I'm Karen Wentworth, a community educator and advocate with Family Crisis Services, a domestic violence agency that serves parts of southern Maine.
Back in 1995, PSR Maine convened a group of experts from all across the state, experts in domestic violence, and basically asked the question, what could a group of physicians and healthcare providers do to be helpful in preventing injury and death related to domestic violence? And what we learned was that the most useful thing we could do would be to train other physicians and healthcare providers in how to routinely screen and refer for domestic violence. We put together this program, which we're going to present to you today with the help of many experts both here in Maine and nationally. This program is usually presented in physicians' offices or clinics with a physician and a domestic violence advocate from the community to provide a sort of face with the name, and that type of program is available to you as well in your practices. Next slide. We have nothing to disclose. We hope today to provide you with an understanding of, first of all, why it's important for doctors and other healthcare providers to routinely screen for domestic violence, to provide you with a set of tools which are efficient and accessible and useful in your practices to routinely screen for domestic violence, to show you how to make your practices a safe and supportive environment for disclosure should that need to happen, and finally to provide you with information about available resources for referral. During this program, you'll have the opportunity to text questions on in the text box to the right of your screen, and our program coordinator, Janie Morse, will compile these, and we will attempt to address as many of them as we can at the end of the program. To receive CME credits, we're required to document that you have, in fact, spent the entire hour with us. So at the end of the hour, I'll provide you with a email address and a code word to email, and we'll give you your CME certificates in return. Now I'm going to turn it over to Karen Wentworth, who will discuss some basic principles and information about domestic violence generally and also here in Maine.
Thank you. Thank you for joining us. Let's start with the definition. Next slide. Domestic violence is when one person in a relationship chooses to use coercive tactics in order to control another. It's a pattern of intimidating and threatening behavior that happens over time and tends to escalate with time. It is not a one-time incident. It is also not stress, anger management, mental illness, or substance abuse. Though those things make domestic violence worse, they do not excuse the behavior. There is no typical victim. Domestic violence can happen to anyone. It happens at all socioeconomic levels, all religions, races, and ethnicities. Lesbians, gays, transgender people also experience relationship abuse. Teenagers, the elderly, and people with disabilities are particularly at risk. According to government statistics, 85 to 95% of offenders are men. To be clear, I did not say that 85 to 95% of men are offenders. And that being said, we know that men are victims of domestic violence, but we don't have accurate data because they tend not to come forward. The material that we're presenting here today is based on research on men's violence against women, but it is possible to generalize it to female offenders, to adult children who offend against their parents, and to teenagers who use these tactics. Because the majority of victims are women, I'm going to use, at times, she for the victim and he for the offender. Next slide. Let's look at some of the tactics that are typically used by offenders. First of all, physical violence is always the top priority, but it is possible to be in an abusive relationship and never be harmed physically. There are many ways to control and abuse a family. Victims tell us that the emotional abuse can sometimes be worse than the physical abuse because of its long-lasting impact. Lowers self-esteem and self-worth. It can lead to depression, and in worst-case scenarios, to self-medication through drugs and alcohol. Sexual coercion, rape, and reproductive manipulation are common in abusive relationships. At one end of the spectrum, we may see rape and a demand for sex, and at the other end, an offender withholding intimacy, telling the victim, "You disgust me, no one would want you, you're too fat." The same with reproductive manipulation. For some offenders, they believe that the woman is going to be more dependent and therefore more easily controlled if she's pregnant. Those men may choose to sabotage birth control, refuse to use it, or refuse to allow it in the home. At the other end, we see offenders who force their partners, their pregnant partners, to get abortions by threatening a beating or threatening life. Perhaps those offenders feel that pregnancy is a way for the woman to control them. I personally have had several women tell me that they were forced to get abortions. Victims tend to get isolated over time in abusive relationships. You may have patients who are in abusive relationships that have moved from a different part of the state or a different part of the country. You may be the only person that they can speak to alone and confidentially. So it's very important that you speak with them privately without the partner there. A partner who insists on remaining in the examining room and who answers questions for your patient, it's a big red flag, and Daniel will talk about that more. Offenders rarely take responsibility for abuse. They will deny it. They will blame the victim, minimize it, and normalize it. And the victim may take on some of this behavior themselves by really even not recognizing that they're being abused, or think that this is normal in a relationship, or try to protect the abuser. If you are in the examining room and the partner, the offender, may try to deny the abuse to you as well and make excuses, say she bruises easily, or she's crazy and she's lying, or she attacked him. Keep in mind that these people can be extremely manipulative and convincing and likable. Children can be used in a myriad of ways by offenders. What we see is the threat of divorce and gaining custody of the kids. We see the offender acting as the favorite parent to the children so that the other parent's authority is undermined. If your patient is on medication for depression, then perhaps the abuser could use that in court and say, she's crazy, she's on antidepressants, she's on medication, I need custody of the children. Male offenders may believe that they have the right to control their family. They may go by the old adage that the man is the king of the castle, that the man wears the pants in the family. They make all the decisions, they decide the gender roles. Abuse is a very effective tactic for them because when people are afraid, they're easy to control. Ask yourself with patients, is there anything suspicious about what's going on around money? Does the partner always pay the copay? Are there strange things going on around medication? Perhaps your patient is asking for free samples or claiming that they can't get to the pharmacy because their partner won't take them. Consider that perhaps the partner is either using the medication themselves, selling the medication, or using it as a weapon against your patient by hiding it or not getting them to the pharmacy in time to get it. Coercion, threats, and intimidation are very powerful tools. It may be as simple as a look from across the room, as body language, or it may be as dramatic as throwing the cat across the room. There's a very strong correlation between pet abuse and domestic violence. One professional woman told me that her husband kept a loaded rifle on the bottom step of their stairway, so every day she had to step over it. You may find that they might try to intimidate you as well, questioning your knowledge, undermining you to your patient, becoming hostile in your office. On the other hand, they may be very charming and likable. And remember, they come from all walks of life. There are attorneys, counselors, clergy, doctors. An abuser can be anyone, just as a victim comes from all walks of life also. Next slide, please. Prevalence in Maine. Every year, 7,000 Maine women are physically, sexually assaulted by an intimate partner, and over half of them are injured as a result. Maine is considered nationally to have one of the highest domestic violence rates in the country, just because every year, nearly half or over half of our homicides are domestics. In 2010, we had 6 women who were killed by their partners or their exes or their husbands. 3 of those were murder-suicides. We did not have any men who were murdered by their intimate partner. Approximately 1,200 women are killed every year. That's about 3 a day. And those women are killed by their intimate partners. 1 in 20 new mothers in Maine report experiencing violence during pregnancy. One of the surprises to me when I started this job and started facilitating support groups was how many women told me that the abuse did not start until they became pregnant. So one of the happiest times in their lives turns into a nightmare. Nationally, 1 in 4 women will be victimized, 1 in 3 Native women, 1 in 3 teenagers, and again, the elderly and people with disabilities also experience high rates of domestic violence. And you'll notice that these statistics are about women. But again, men experience domestic violence, and our projects, the domestic violence projects, do meet their needs. Next slide, please. Diversity. There are many special populations that have significant barriers to seeking help. Native American tribes, each tribe is a separate culture. Each individual within that tribe is an individual with their own beliefs. So it's important to ask questions, to say you don't know. Generally speaking, with tribes, you want to ask less direct questions, be more sensitive, allow more time for silence. And that may hold true for immigrants, refugees, and newcomers as well. Immigrants may fear deportation. Refugees do not have terminology for domestic violence. And if you ask them, do you feel safe at home? Well, compared to a refugee camp, yes, they do feel safe. So each culture has to be treated with sensitivity. Elder abuse, underreported, seems to be on the uprise. More, it's not just spousal abuse, it's also adult children and caretakers. People with disabilities are victims of crime at 1.5 rate of the general population. Many people with disabilities have had their boundaries violated by caretakers through the years. Some well-intentioned, others not so well-intentioned. So that's an extra caution that should be taken. So when working with any of these groups, it's really, they have unique needs, and being sensitive to those is really essential. And keep in mind that the domestic projects are here to help you. Next slide, please. The most common question that we get asked as domestic violence educators is, why does she stay? And it's a reasonable question. You see newspaper articles and things on the news that you just can't believe that someone can stay in the relationship. The more that I do this work, the more I wonder how anyone is ever brave enough to leave the relationship. It's the most dangerous time. The majority of domestic violence homicides occur when a woman is trying to leave. So fear of harm or death is a very big reason of stalking, of staying within a relationship. But let's back up. It started as a love relationship. There's an emotional bond there. That doesn't go away easily. Perhaps they're children, and people want to keep the family together. Hope is a big one. The relationship did not start off abusive. And in many relationships, there's a cycle, so that there are times that are really wonderful and then times that are bad. Some women have explained it as living with Jekyll and Hyde. The abuser is a monster, and then back comes the wonderful person that she fell in love with. So that keeps the hope that things will change going. Economic hardship, along with isolation, makes it extremely difficult for someone to get out of a relationship, and really almost impossible without the help of the community. And that's something we have to keep in mind, that domestic violence is a community health problem. We can all help domestic violence projects, healthcare providers, and other service providers in the area. Marriage vows, very important. Many clergy will tell women to go back home. They took a vow to keep the family together, to forgive. It's very difficult also for someone to come forward and then risk losing their congregation. The same for gay and lesbians, who often come from a very small community, and if they come out and leave the relationship, they also leave all of their social contacts, tribal members, churches. So for many people, it's difficult to come out and be isolated by that process. So the question is not, why doesn't she leave, but how can we best assist her if she can't leave? And if she does choose to leave, how can we keep her safe and support her to the best that we can? At the end of this training, you're going to have the opportunity to email your questions. That was just a really brief overview. So if there's anything that I didn't make clear or that you'd like more information about, then please email at the end. And right now, Daniel's going to present information that is specific to healthcare. Thank you.
Excuse me. Thank you, Karen. So we, as healthcare providers, have an extremely important role in breaking this cycle of violence, or at least helping to try to break this cycle of violence within abusive relationships. This has been recognized by many professional and public health organizations. In fact, in some states, specific training in domestic violence is required for licensure or relicensure. When survivors of abuse are interviewed about what might have made a difference, what they say is, very often, if only my doctor had asked, if only I was able to talk with my nurse practitioner about this, maybe I could have gotten some help. Maybe we could have put a stop to this. Remember, as Karen alluded to, very often the doctor's office is the only place where she can be alone with someone other than her abuser. He's controlling where she goes, who she talks to, what she does, but going to the doctors is something that sometimes he will let her do alone. And so you have the opportunity under those circumstances, with the door closed in the exam room, to ask the appropriate questions and potentially intervene, as we'll talk about. It's also true that a very substantial fraction of women who are killed or injured seriously in a domestic relationship, domestic violence, intimate partner relationship, have seen a healthcare provider in the preceding year. But in only a minority of cases were they asked about domestic violence. Next slide. So our role is to try to help to break this cycle by, first of all, routinely screening for domestic violence. We'll talk more about what routinely means, but routinely fundamentally means all the time, every time, routinely. It may not mean every visit. It may mean every time you see a new patient and once a year thereafter. It may mean when she changes her life circumstances, leaves a relationship, gets divorced, gets a new boyfriend, remarries. Every office and every practice will need to develop your own screening policy, but routinely fundamentally means when there are not necessarily any signs or symptoms that any abuse is going on. The same way you would routinely ask about smoking or seatbelt use or bicycle helmet use. It needs to become part of the routine history that you take with patients. Remember that screening itself is an intervention. Asking the question itself is an intervention. It communicates that you care, that you know that this is something very important, that this is a safe place for disclosure, and that you are available and an available resource to help. Our job is not to fix the problem. We can't fix this problem. We're trained to try to fix problems. Someone has a strep throat, we want to give them antibiotics. This is not a problem that we can fix. What we can do is provide options, that we can emphasize safety, we can create a safe environment for disclosure, and we need to remember that we don't know what's right for her. She is the only one who knows what's right for her. Should she stay? Should she leave? When should she leave? What about the children? Again, as Karen said, leaving, when she leaves, is the most dangerous time of all. That's when most serious injuries and murders happen in intimate partner relationships. In addition, in some way communicating that we know what's right for her or what she should do simply recreates the power dynamic that she's suffering already. And we don't want to be yet another person telling her what to do. We need to explain that we care as her health care provider. We care about her health in all its aspects, and that we want her to know that there are resources that are easily available and accessible. It's important to know the mandated reporting laws in the state that you work in. Every state has different mandated reporting laws. Know the laws in your state. In Maine, we are not mandated reporters, nor should we, in my opinion, be mandated reporters for domestic violence. We need to be able to tell our patients that whatever they say is completely confidential, will never leave the office, and will never lead to any intervention by anyone without her initiating the process. We are mandated reporters for when it involves child abuse, when it involves elder abuse and abuse of dependents, and when a firearm is involved. But otherwise, no. Next slide, please. Now, while it's important to screen routinely, it's equally important not to ignore red flags. There are all kinds of red flags. There are physical signs, things like injuries that don't match the story, bruises in various stages of healing, central injuries that are hidden by clothing, injuries along the surfaces of the arms that would imply a defensive posture, complaints that don't lead to any findings, repeated complaints of abdominal pain, which is there month after month despite extensive workup, Patients going from one type of specialist to another, or one doctor's office to another, with repeated complaints that never seem to result in a clear diagnosis. Instead of thinking of this person as, crazy or a crock, in fact, this may be a cry for help, and it's important to recognize and ask the appropriate questions under those circumstances. Injuries during pregnancy, as Karen said, this is one of the most dangerous times in an abused woman's life when she becomes pregnant. So being especially sensitive to injuries that occur during pregnancy. There are administrative red flags, like appointments being canceled by her husband. Many offices have a policy that if anyone other than the patient calls and cancels an appointment, there is literally a red flag placed on that chart to alert the provider that this is something that needs to be investigated. There's much written about red flags, signs, and symptoms of abuse, but that's the kind of example that we should think about. Now, Karen made reference to one other very important red flag, and that is the man who won't leave. The man who talks for her, who answers the questions for her, who butts in, who disagrees with what he's saying, who belittles her symptoms, and who won't leave the room. Since one of the very important principles of screening for domestic violence, as I'll get to in a minute, is to always ask the questions when you are alone with the patient, never with anyone else. Sometimes the biggest barrier for our ability to do that is getting him out of the room. And sometimes it's impossible. It's important to have some sort of policy in the office, in the practice, if you can, whereby even for a brief time the patient is separated from the spouse, be it with a nurse taking her to the bathroom for a urine sample or whatever it may be, even when no urine sample is needed, in order to ask the question. Sometimes it's not the doctor or the nurse practitioner who's asking the question. Sometimes in some offices it's the nurse who's doing the screening because she's trained and has the ability to separate the patient from the potential perpetrator. Next slide, please. So we all love acronyms. And here's the acronym for the process to help us remember how to go through domestic violence screening and referral, RADAR. The first R stands for routinely screen. And as I said earlier, what routinely means is going to vary depending on the specifics of your practice. But in any case, certainly all adult women should be screened the first time you meet them and probably annually thereafter or when there are important changes in life circumstances. Pregnant women should probably be screened several times during the pregnancy. As Karen mentioned, men in same-sex relationships are at equal risk of abuse as women in heterosexual relationships. However, the data are there aren't as many data to give us the kind of firm guidance that we wish we had for figuring out who and when to screen men. But certainly under those circumstances, or if there's any suspicion, men should be screened as well. The A in RADAR is for ask. Interview the patient alone. I can't say it enough. This means not her best friend there, not her mother there, not her sister there, not her 4-year-old kid there. You might think, well, it's a little 4-year-old kid, what can it matter? You can imagine easily that the 4-year-old child goes home and says, Daddy, the doctor asked Mommy if you hit her, and she said no, but I know you hit her. You will never see that patient again in your office. Everyone needs to develop their own style and comfort with the specific question or questions that you ask. We did a small study here in southern Maine, in fact all over Maine, asking or presenting to healthcare providers, domestic violence advocates, project directors, shelter workers, and abused women in shelters, presented to them a large number of questions and ways of asking the questions. And these three types of questions sort of bubbled up to the surface as those most likely to make a person feel comfortable enough to disclose ongoing abuse. The first we're calling an indirect question. That means something like, as part of the social history, who do you live with? Is he treating you kindly? Does he hurt you in any way? It will be usually very clear from the answer, body language, facial expression, when she says no to questions like that, that she really is okay. But still, the question communicates that you care and that you're available should she ever choose to talk about something that she isn't choosing to talk about today. Direct questions are things like, is anyone hurting you or threatening to hurt you, either physically, sexually, or emotionally? Just asking directly. Some people feel more comfortable, just like you would say, are you smoking? How much do you smoke? And then there's what we're calling a framing question, to put the question in context so that you may not feel that she may feel she's being singled out in some way. We know domestic abuse is a very common problem. We ask all of our patients, do you feel unsafe around, or have you ever been threatened by a current or former partner, family, or household member? To me, this feels a little stiff and formulaic, but for some people, it's exactly what they need to do because that's what they feel most comfortable doing. You'll develop your own style. If she says no, but you still have some concerns for whatever reason, and after all, we're clinicians and we have a certain degree of clinical intuition which we need to respect. So sometimes, even when she says no, we suspect there might be something going on. Obviously, we respect her answer. We don't challenge her or denigrate her as if we know and she's just choosing to lie to us. We accept what she says. We remember to ask again in the future. We may nonetheless offer materials and information in the context of saying something like, well, unfortunately, this is a terrifically common problem. Perhaps you'd like to take a look at this material in case it might be useful to you or a friend or a family member. If there are any physical findings to document, it's very important to document them, even if she says no. Remember that when studies are done of abused women, on average, it takes 7 times of being asked, 7 different episodes, either in emergency rooms or doctor's offices, before disclosure happens. Next slide, please. Now, if she says yes, again, our job is not to fix this. Our job is to express to her that we care because we're her health care provider and we care about all aspects of her health, to convey that this is not okay, that she did not bring this upon herself or deserve it in some way, and that there are resources in the community that are available to her right then and there or at any time in the future, resources provided by true experts in the field, people who do this work all the time with a very large array of services to help. And Karen will talk a little bit more about that later. The statement here is an example. I'm sorry this is happening to you. It's not your fault, and there are people who can help. That's the fundamental message. Whether it's delivered in that way, obviously, will vary under each circumstance. Next slide, please. The D in RADAR is for documentation. Documentation is extremely important. It conveys to other healthcare providers that this is an important medical issue. It, if there is multiple access to the record in a healthcare system, it alerts other providers that this patient may be suffering ongoing abuse in an intimate partner relationship. It increases awareness of domestic violence in general. And it provides corroboration of abuse, meaning that if it is ongoing and if something tragic ever happens and it does enter the legal system, you are very, very well protected as a provider if you have careful and precise documentation of the disclosure. It is much more difficult if you are asked to testify in some way and you don't have good documentation or being asked to remember in some vague way a vague impression than if you are able to open your record and say, here's what she said. Which brings us to the next point. Verbatim quotes. Nothing vague, no impressions. Exact verbatim quotes. The patient stated that her boyfriend, Bob, punched her in the face at 8 p.m. on Tuesday because he told her she came in an hour later than she said she would, unquote, or whatever it may be. That will make it much, much easier in the future, both to protect her and to allow you to convey the information precisely and safely. Obviously, documenting any physical signs of abuse, any referrals that you make with the name of the contact. As we'll talk about, she may need to make a phone call right then and there. If she does, make sure you document what the number was that she called and who she spoke with. And it's important to document any follow-up plans that you make. You may want to see her in a week to explore this further or talk further, or to examine her injuries and provide yourself with another opportunity to ask her about how it happened. That needs to be documented as well. Next slide. The second A in RADAR is assess. Assess the patient's safety. This means make sure that she feels safe leaving the office and going home. There are times when she may not. This may be the moment when she needs to get out, the moment that she's just disclosed to you what's going on. If that's true, if she's in immediate danger, all we need to do is provide her with a room and a phone number so that she can get the help she needs right away. Again, our job isn't to fix it. Sometimes we even need to be the one to make the phone call because she's so incredibly shook up. But with her permission, after we get the shelter worker or the project advocate on the phone, we can hand the phone to her, close the door, and let them take it from there. make sure that she feels the kids are safe. And again, those same resources are available to help with safety planning for both herself and for the children. Now, the last R in radar is for refer, and Karen is going to talk more about resources that are available and what to do about referral.
Okay. That number, 1-866-834-4357. It's a statewide hotline number that is available 24 hours a day, 7 days a week. It's free and it's confidential. It is for you as well as for victims and for anyone who is trying to support a victim. Once you call that number, you'll automatically be transferred to a domestic violence project in your area, and you can find out from there what services are available, how you can receive help. You can call right from your office, as Daniel said, and an advocate will be available to talk to the victim and to lay out options and see how she wants to proceed. We can also come and meet her. Domestic violence agencies are found throughout the state of Maine and throughout the country, actually. And we all offer the same services. They include crisis intervention, safety planning. Again, as Daniel said, you want to assess for safety, but please leave the safety planning up to us. You don't have to be experts in that. We have people who do that 40 hours a week as their full-time job. They also help with protection orders and give legal referrals. We have emergency shelters for women and children, and all kinds of advocacy for incarcerated women, for elderly, for teenagers. We do prevention education as well, and we also do staff training, be it clergy, counseling, healthcare providers. Any employer will go and do training around domestic violence and how to be aware of it and refer. Remember that to refer victims to our hotline, and also it's always there for you, and that our services are available for both men and women. Daniel and I are going to demonstrate how to screen, and we just need a moment to set up for that. So hold on, and we will be right back.
So I've just finished taking a history, past medical history, family history, so forth, from my new patient, Karen, who I'm meeting for the first time. And I'm moving on to the social history, and I've probably asked a few questions about smoking and so forth. Who do you live with?
I live with my husband.
And how long have you been married?
We have been married 30 years.
Wow,
30,
great,
yeah.
great. He treats you kindly, doesn't hurt you in any way, treats you well?
Yeah, he does treat me kindly. That's a good word for it. Like any marriage, we have had our ups and downs, but for the most part, I feel really fortunate.
Great. I'm happy to hear that.
Thank you for asking.
I ask everybody. Great. That took less than a minute. Now we'll do it a little differently. So who do you live with?
I live with my husband.
Great. And how are things going? Does he treat you well? Does he treat you kindly? Does he hurt you in any way?
I wouldn't say he treats me kindly. No, I don't. I wouldn't say that. We've been together 30 years. You know, it's a long time.
What do you mean he doesn't treat you kindly?
He's not, I guess, you know, I love him, of course, but he's not a very nice man, you know.
Not nice in what way?
Well, he is cranky and never always complaining, and he's a bully. He bullies me.
What does he do when he bullies you?
He demands his own way. If I say the wrong thing, he snaps my head off. It's always just got to be so careful around him all the time. It's exhausting.
I bet. Snaps your head off?
You know, barks at me, you know, that kind of thing.
Does he hurt you physically?
He has. There have been some incidences where he's, gone too far. Nothing serious. I'm not like a battered woman or anything. It's not. He doesn't beat me.
Mm-hmm. What do you mean gone too far?
He's pushed me, and he's slammed me into walls. It's hard to say.
Yeah. When was the last time that happened?
A few months ago, I think. And it's not happening all the time. It doesn't happen every day, but it's always there.
Do you feel scared when he's like that?
Yeah. I try to offset it best I can. I can feel it building, so I'll try to distract, which sometimes works and sometimes doesn't. So, really not sure. I don't know.
Well, I am really sorry to hear that this is happening. You need to know that this is not okay. It's not behavior that's acceptable. It's not something that you did to bring it on. And it really, really concerns me as your doctor that things could conceivably get even worse, that you could get seriously hurt. I have no idea what the right thing is for you to do, but I just want you to know that I'm concerned about this, that you can talk with me about this anytime you want. I'm not an expert, but you need to know that right here in this community there are experts who can really help you sort this through and give you options and resources. In fact, I have a card right here that I can give you that has their phone number on it. Now, you may not feel safe taking this number home in case he finds it. Sometimes, unfortunately, that can be very dangerous. If you feel okay about taking it home and hiding it someplace, feel free. But if not, you can memorize it right here. It's a pretty easy number. Also, on the inside of every phone book, not that we have many phone books anymore, but the inside of phone books in Maine is this very same number that's accessible. And it's accessible online. So if you want to, take the information, but just know that I'm really concerned, and I'm here to help in any way that I can.
Okay. Thank you.
So, now let's talk about your thyroid.
Okay.
Okay. So that took maybe 4 minutes, maybe 5, I'm not sure. 3 minutes, I'm told. So it isn't a huge time drain, and that may be all that's necessary to plant the seed. So the bottom line is screening for DV matters. It's important. It's easy to do. You'll develop your own techniques and style in terms of questions and when in the interview and how in the interview you ask. But it will rapidly become comfortable and familiar. So we hope that this information has been useful and that you'll you'll take the plunge if you're not already screening routinely and begin trying to use this in your practice and try to make a difference. Remember that the resources that we've told you about aren't just for patients and victims of domestic abuse, but also for providers. There's lots of people there who can help with specific situations. If you have specific questions or general principles, that's what they're there for. You can also always call our program director, Janie Morse, whose contact information is at the bottom right of this slide. She can also help set up a training directly in your practice. Janie's also been compiling questions, which you've been emailing, and I think we have time to address a few of those now. I think Paul our executive director of PSR Maine will convey those questions.
Yep. Okay. Can you hear me? Okay. Okay. Yeah, we have a couple questions. One of which is about providing hotline number information and other information safely. Now, you did sort of demonstrate that, but can you go over that again? What to do if giving printed material is in fact unsafe?
Right. And Karen can probably speak to this more than I, but sometimes that's a very dangerous thing to do. If he's exceedingly controlling, he'll be going through her purse, going through her drawers, looking for evidence that she's been doing something she hasn't told him about, or cheating on him, or whatever it may be, and he could come across this, and this could trigger a huge violent response. So it can be very, very dangerous for her to actually have something with a phone number on it. There are ways to write down the phone number without saying what it's for, or putting some other name, Hannaford Central Office, and then the number, whatever it may be. I think in the day, the projects used to provide nail files, I think, with
Yep.
the number printed on it,
Yes.
with a sort of a cosmetic company a logo or something like that. I mean, there are many ways to do it. Sometimes just memorizing the number, 1-866-834-HELP.
And we found, I don't know if it works in physicians' offices, but we found that one of the most successful ways is to have tear-off sheets in the inside stall of the woman's room, so that they can close the door of the stall and just tear off the number. And those can go very rapidly. And also, if they're working with any other service providers, sometimes they'll make up, say, a housing appointment. It looks like an appointment for housing when actually the person is coming to see us. So the more that the victim confides with other people, the more ways we can find to help her and get her the support she needs.
Okay, thank you. Another question for Daniel. Can you give us an example of how screening has worked in your practice in real life? What can one expect when doing this?
Well, in real life, I screen everybody at their first visit, and whenever there's a change in circumstance. Everybody meaning all women and men in same-sex relationships, or if there's some special circumstance. I ask the question routinely, and by and large, the overwhelming response is no. I feel I'm good. Everything's good. And again, there's often a smile and a nod, and I'm lucky. He's the sweetest guy, whatever it may be. And it's so fast, and we move on. Certainly, sometimes there have been disclosures, even to the point where she's had to make a phone call in the next office. It doesn't happen very often, but when it does, the resources are there, and I'm on to my next patient. And sometimes she's extremely grateful for the intervention. And the intervention is just asking. Sometimes it's tricky and complicated. I'll give you an example from just the other day. I was seeing a new patient, and she came with her husband, who is from another country. She's American. And we went through the whole medical issue, and then at the end, the husband said, well, I want to know the numbers. I want to know the result of every one of the blood tests. I want to know the exact number, because I like to be in control of the situation, he said. And I said, well, that's fine. With your wife's permission, I'll give you the numbers. But I also said, I need you to know that she's my patient, and she's the one that I have the relationship with. I then got an email the next day from him, the husband. I have no idea how he got my email. I don't communicate with patients on email. But he was unhappy with the way he was treated. And what apparently he meant by that was that I was essentially focusing on my patient, that I was speaking to her directly, and he felt in some way excluded from the conversation. And maybe I did, to some extent, do that. I'm not sure. But in any case, now I have two important red flags. And so I called her when her test results were back. I made sure to call her on her cell phone. I asked her first if she was alone, and she was. And I asked her if she was aware that her husband had emailed me. And she said she was, but she didn't know the exact contents of the email. I read her the email. And I said, I have a question I need to ask you. I would have asked you this had you been alone, but I'm glad to have the opportunity to ask you now. And that is, about safety and harm and so forth, standard DV screening questions. She assured me that she was in a safe relationship. They'd been married 17 years. They have 3 kids. And she attributed his response and his use of the term control to cultural differences. She said, he's been here a long time, but there are just still some things about the United States he still doesn't get. And he says things like that, but it doesn't mean, control in the same way, and I'm fine. And I said, well, I'm glad to hear that, but I'm always here and available if you need to talk about anything like this further. And, I'm glad that you're doing okay.
Okay, thanks, Daniel. We've got one more question, and we've got about 2 minutes left before it's 9 o'clock. And this is for either of you, I think. And I'll just read it verbatim off the chat here. Regarding children, the court systems often dispute, quote, violence with, quote, discipline. How do you help to encourage your patients to still move forward in reporting violence against her and her family, despite that situation?
Honestly, I'm not sure I understand the question.
If I understand it, the question is about parents disciplining their children in a way that might be viewed as abusive, perhaps? Is that your sense, Paul, of what the question is? I think it's important to distinguish, whether that's the question or not, it's important to distinguish child abuse from domestic violence. We are mandated reporters for child abuse. Again, our job is only to report if we suspect it. DHS takes care of the investigation and makes a determination as to whether there is or is not abuse going on. But that's very different than a patient disclosing to her doctor that she's being beat up by her husband.
So another way to put it, a more specific question then is, do you actually encourage patients to report violence, or are you more sort of neutral about it?
We don't do. We're because of our funding, we have really very, very tight confidentiality regulations. So we do not encourage women to make any decisions that they're not comfortable with. It's all about their comfort level. And I think that answers the question. Again, we're mandatory reporters also, so we tell the women right up front, if you disclose child abuse or you're going to harm yourself or someone else, then we are mandated reporters. But it's up to the woman to decide what she's going to disclose. Thank you.